Okay. Very good evening, doctors. I welcome you all because all participants are from various parts of the country. I am Anil Sharma and working as a cluster head and vice president with the chronic cluster of India Bulls. As you know, India Bulls is a financial company which comes in top three financial companies of India. And in pharma business, India Bulls has entered just 3 years back and is restructured its business in 2018 November by with adding three clusters. One is acute, one is dermatology and gynae, and one is chronic cluster. We have overall 9 divisions, and we have closed our year with around 120 crore turnover in the last year. And as you know, we have a prescriber base of around 25,000 doctors and prescription base of around 7 lakhs per month, which has been registered recently. As far as chronic therapy is concerned, that we always have a business philosophy to deal in academic programs. We have various academic programs which we have initiated like NEEV, Converge. And considering COVID-19 epidemic, which has been impacted one and all the other way, and we have initiated this online learning platform, eGurukul, and which is the program where we have eminent super specialists and academicians who participate and come and share their experience, because we understand that this period is very difficult for all industries and for everyone. And I thanks and always respect for all the doctors and nurses and paramedical staff who are contributing not only for the patients but also to the society in this epidemic. So I sincerely thanks our eminent speaker for today, Dr. Vinayak Agarwal is a cardiologist, and Dr. Prabhat Goyal is a diabetologist and consulting physicians with a lot of interest in academics. I'm sure that today's program, because a lot of webinars are going on, but you all will have a lot of learnings and experience sharing in this webinar. With this, without not taking much of your time, I will request our medical advisor, Dr. Abhay Mane, who can introduce today's eminent speaker who will speak on today. Thank you very much.
Okay, sir. Thank you, Anil, sir. Thank you so much. Good evening, everybody. And I welcome you all again to this eGurukul program, the webinar hosted by India Bulls Pharma. Not only speakers, but I also heartily welcome all the audiences who are showing a lot of interest in our webinars. Myself, Dr. Abhay Mane, working in the medical team of India Bulls Pharma. We also have Vaneet sir with us, Vaneet Sarin sir, who is heading the marketing team. So what we are going to talk today is basically we have two talks. So our first talk will be hypertension management, which is a cardiology talk in COVID pandemic. So for our first talk, we have Dr. Vinayak Agarwal, who hails from Delhi. He's a director and head of Department of Clinical Cardiology and Cardiac Imaging at PSRI New Delhi. He brings along more than 2 decades of experience. He's not only MD, DM cardiologist, but he's also a recipient of prestigious FACC, FAAC, and FAHA. He has been instrumental and pioneer in developing heart valve clinic, liver transplant cardiology division at Medanta. Dr. Agarwal has delivered more than 200 scientific talks, lectures as an invited faculty, and he has more than 30 national and international publications to his credit. And if I keep talking on his accolades, I think I'll talk for 1 more hour. So I welcome Dr. Agarwal today, and so we are blessed to have you here. After this topic, we will also have a very short video, a 4-minute but extremely informative video on the insulin sensors and blood glucose levels, which will be presented by Dr. Peter Gillard from Belgium, who is a renowned international speaker in the field of endocrinology. For our second talk, which is the management of diabetes mellitus during COVID pandemic, we have a stalwart Dr. Prabhat Goyal in the field of diabetes and endocrinology. He has his own setup in Gurgaon and brings more than 20 years of experience, not only in diabetes, but also in the critical care. He has attended many international and national conferences. He's a member of prestigious bodies like RSSDI. He has delivered more than 50 talks and scientific lectures. Dr. Goel also brings academic experience. He was associated with MGIMS Sevagram as a lecturer in the Department of Medicine. So, sir, thank you so much for joining us today. And after this talk, we will have a question and answer session. So I have a link to questions, so speakers don't need to worry. I'll note down all the questions and I'll read the questions for you. And after that, we will, with the vote of thanks, we will end our today's session. So I request Dr. Vinayak Agarwal to start presenting his slides. So please take us through the first talk. Thank you so much.
Thank you, Azay.
Thank you.
Thank you, Anilji. Thank you, Vineet and Abhay and dear Dr. Prabhat. It's a pleasure to be here with this very important, interesting, actually, concepts of hypertension in COVID era. Now, it may sound a very, simple kind of a thing. Maybe I can finish the talk in 2-3 minutes and say that, well, you continue with the management of hypertension exactly the way you were doing it before pandemic era. But it's not so simple, actually. There are many nuances to it, some very interesting theories that I would like to mention during this talk. First, I'm going to briefly take you through hypertension, how we deal with it in the present era, right? Very brief, 5 minutes, because that's going to set up the perspective for what will follow. Now, we know that hypertension is, as we say, is the silent killer. And if you look at the fact that in Europe alone, there are 150 million people who are affected, and prevalence is expected to rise by about 15 to 20% in another 5 years. And if you look at the world population at large, almost 1 in 7 or 8 people is actually hypertensive. Now, look at India. India is 1.3 billion, which is 1,300 million people in this country of our country, and the prevalence is 25% or higher. So you can imagine how much burden of hypertension is there in India. And more the age, so above the age of 70 years, almost 60% of the population, elderly population, will have hypertension. And unfortunately, if you look at the data, whatever little data that we have from India, the blood pressure control is hardly in the so-called the targets, within the targets is hardly 15%. And there is a double whammy, because not only hypertension is directly related to the amount of ischemic deaths, so higher the blood pressure, more is the deaths from ischemic heart disease, but look at the financial burden in a country like ours, where only 3% of the GDP is spent on health. And we are seeing the impact of dismal healthcare delivery in our country during COVID times. And if you extend this double whammy to hypertension and its impact, you can see where India stands. And you're looking at enormous amounts of strokes and CV deaths in India, including financial as well as clinical burden. On top of that, there is a lot of confusion which American and European guidelines have given us, because both of them have different, say, guidelines, different target blood pressure measurements that they propose. And if you look at the American guidelines, they're largely driven by meta-analysis, and one of the most prominent ones being SPRINT. And the European guidelines are largely based on the population attributable risk. And in a nutshell, this slide will tell you the difference that, for example, the ACC, American Heart Association, gives a definition of hypertension above 130/80, while ESC, European guidelines, say it more than 140/90. The normal optimal is about 120/80 in both, but the moment it goes above 120 systolic, it is known as elevated in American guidelines, whereas it is normal in European guidelines. High normal is 130 to 140, and 85 to 90 range is your high normal in European guidelines. But when you look at the grade 1 hypertension, it actually is very similar to the high normal of European guidelines with slight difference. So the grade 2 is more than 140/90, which in grade 2 in European is 160 to 180 and 100 to 110. And there is no grade 3 hypertension in American guidelines, while more than 180 to 110 is grade 3. Something which we also call as hypertensive urgencies. If they are associated with target organ damage, then they're known as hypertensive emergencies. So if you look at the targets which ACC and ESC give, they're vastly different. So how are you going to actually know the prevalence or incidence of hypertension? They will markedly differ from one guideline to the other. The other is the concept of what we call as a white coat hypertension. When you go to the clinic of a doctor, the blood pressure may be high. When you go home and check it, it's normal. So that's called white coat hypertension. So sometimes when you are at home, your blood pressure is high, but when you come to the clinic, it is actually normal. That is called masked hypertension. And of course, when you have both being high, it is sustained hypertension. And if both are normal, then it is normotensive. And there are different guidelines. One very important concept is to also look at the night dipping, which should be less than, the blood pressure should fall by about 10 to 20% below the 120/70 is the normal cutoff. So these are the important concepts which we must talk about. Coming to the medications, so the concept of a single pill having 2 drug combination is what is preferred now. So there is a single pill concept where you can combine one group with the other group of medications. And the core treatment strategy still remains as what we call as the ACD. So ACE inhibitors or ARBs, calcium channel blockers, and diuretics. That is your number 1, 2, 3 in any of the combinations is what your core treatment strategy. And the beta blockers are to be given only when you have heart failure or coronary artery disease. Ischemic heart disease subset is where you're going to be giving beta blockers specifically, or where you suspect that there is a high sympathetic activation. When do you add them? Most of us tend to add blood pressure medications when the lifestyle advice fails or management fails. Certainly in grade 2 and grade 3, we will be giving antihypertensives. And the way to give it, as I was saying, try one pill with ACE inhibitors, ARBs, calcium channel blockers, or diuretics. So ACD is your number 1 initial therapy, either 2 or 3 in combination. And once there is resistant hypertension, when it is not controlled by these 3, you add spironolactone. Beta blockers, as I was telling you, are only for ischemic heart disease, post-MI, AF, rate control, heart failure, etc. Now, this is the background I wanted to give you. And here is where I emphasize, look at the ACE and ARBs. Now, if you, for some reason, there was a lot of controversy which was being generated when the COVID-19 era came. And initially, some papers said that ACE and ARBs, the people who were using ACE or ACE inhibitors or ARBs will have higher mortality if we give these drugs. And a lot of people actually withdrew in the first month of COVID era, somewhere around March or so. A lot of people actually withdrew ACE inhibitors in the ARBs. Still, most of the guidelines came back saying that, you should not do this. And we are going to revisit that data now. Now, what is the pathological link between hypertension and COVID? So when you look at the initial prevalence of the prevalence of hypertension in patients of COVID, we saw that more patients who went to the ICUs or who died actually had pre-existing hypertension. And initial reports from Wuhan, from China, that one of the commonest comorbidities which was seen in patients who went onto the ventilators secondary to the ARDS or severe respiratory complications of COVID-19, 20 to 30% of them actually had hypertension. And if you look at the way ACE inhibitors are, centered around, there is a very simple concept to understand that the angiotensinogen in a normal RAS system is converted to angiotensin 1 by renin, which is converted to angiotensin 2 by ACE, ACE enzyme. And this angiotensin 2 actually is detrimental to the body because it acts through AT1 receptors and activates aldosterone and antidiuretic hormone that is increased hypertrophy, left ventricular hypertrophy, vascular hypertrophy, and increased cell proliferation, vasoconstriction, fibrosis, and apoptosis which occurs. While the same angiotensin 2 is actually deactivated by the ACE2 the receptors and degraded, and the angiotensin 1 is actually converted into angiotensin 1-17, and the MAS receptor is activated, which is counterbalancing in a good way, and there is vasodilatation, anti-inflammatory, anti-fibrotic, and anti-proliferative properties. So we know that the ACE2 inhibitor is key in delivering. The higher the ACE2 levels, receptor levels, higher will be your good effects of on the body. So anything which blocks the angiotensin 2 receptors will actually have, or angiotensin 2 will have a greater effect on the body in terms of good effects. So more vasodilatation, anti-inflammatory, anti-fibrotic properties. Now, in pathology of coronavirus or COVID, it basically involves the virus is known as the SARS-CoV-2, which binds to the host receptor angiotensin converting to ACE2 receptors. So the virus, coronavirus, which is SARS-CoV-2, enters the host or our body through the ACE2 receptors. These receptors are actually present on the cell surface. The virus attaches through the S protein onto the ACE2 receptors and enters the body. And this ACE2 is expressed in the lungs, heart, and blood vessels, and is the key member of RAS system, which I've just shown you. So there is a dysregulation of the RAS ACE2 system due to SARS-CoV infection, and also when there is comorbidities due to hypertension. Now, if you look at this, the SARS-CoV-2 virus, which has a S protein spikes, it basically enters the body through the ACE2 receptor pathway, and through the caltharin-dependent ACE2 SARS-CoV complex, there is endocytosis of this virus. It enters into the cell, and then the virus binding stimulates TNF-alpha mediated ACE2 ectodomain shedding. So there is basically the virus enters the human cell via the ACE2 pathway or ACE2 receptors. When you look at the ACE inhibitors or ARBs and the ACE2, so there is no direct interaction between the two, but it basically, when you give ACE inhibitors or ARBs, it up-titrates the ACE2 receptor levels through the feedback mechanism. And there are certain other drugs which have been shown to elevate ACE2 receptors, SGLT2 inhibitors and thiazolidones, which are being given for antidiabetics, which Dr. Prabhat Goel will be discussing. And in a nutshell, the ACE inhibitors or ARBs, they act on the angiotensin, the RAS system, and they basically, these inhibitors prevent the harmful effects of angiotensin 2, and they increase the good effects of ACE2 mediated anti-inflammatory and anti-proliferative through the angiotensin 1-7 and MAS pathways. So the ACE2 receptors degrade angiotensin 2 into angiotensin 1-7 and the MAS pathway, which are anti-inflammatory. So all these ACE inhibitors, ARBs, actually upregulate, and including the MRAs like aldosterone, the aldactone or eplerenone, also upregulate the ACE2 inhibitors activity and expression. They reduce the harmful vasoconstriction, sodium retention, and fibrosis due to angiotensin 2, and hence actually have a protective role in COVID. So if you look at the COVID infection, it reduces the ACE2 expression, causes more cellular damage, more inflammation, and leading to ARDS or severe respiratory distress syndrome. When you look at the, I will go further. If you look at the potential benefits of RAS blockers in COVID-19, they basically upregulate ACE2, as I have mentioned, and prevent lung injury. But there is a school of thought initially in March 2020 which said that ACE2 inhibitors, since if you ACE and ARBs upregulate the ACE2 inhibitors, and the virus actually enters the body through ACE2 pathways, hence the ACE2 receptor upregulation will facilitate the coronavirus entry, multiplication, spread, and pathogenesis. So there was a very significant concern that the people who were on ACE inhibitors or ARBs, or patients who were COVID patients but having hypertension, not to give ACE inhibitors or ARBs, and that's how the controversy came up and grew. So this was one paper which came very early on in European Heart Journal, where should inhibitors of renin-angiotensin system be withdrawn in patients with COVID-19? And let us examine. So the first evidence I'm going to give you is from NEJM 2020. This was a retrospective cohort of nearly 13,000 patients in New York. Out of these, about 47% tested positive for COVID-19. This study by Reynolds found no association between ACE inhibitors or ARBs use and patients with COVID-19 positivity, or leading to increased severity or mortality. So that was evidence number one. Evidence number two was from the Italian cohort of 30,000 of around 6,500 patients, which were compared to 30,000 cohort, which were matched controls. The cases were 10% more likely to be on ACE inhibitors treatment compared to controls. However, this difference disappeared when you adjusted for higher prevalence of CVD among cases. So when you remove the confounding effect of CVD, cardiovascular disease, in these 6,500 patients, there was no difference between the severity, mortality of COVID patients in these 6,500 patients. So they were found to be safe. ACE inhibitors and ARBs were found to be safe. Third evidence came from the, this was actually Mehra et al. Who published in NEJM, where they actually came up with the theory that the odds of death due to COVID-19 were not significantly higher for those who were on ACE inhibitors, ARBs. But there was a lot of controversy which was generated by this report in NEJM, and it was actually retracted because there was evidence that this study was fudged. It was actually the results were falsified, and hence this study was withdrawn, and it created a lot of bad blood among the medical community about the authenticity or credence of really good journals like NEJM. The evidence 4 came from European Heart Journal 2020, which was in heart failure patients. Again, no increase in severity of COVID patients was seen with ACE inhibitors or ARB use. Zhang and colleagues studied around 3,500 patients of COVID in China, and they assessed the in-hospital use of ACE inhibitors, ARBs, and they reported a lower risk actually of all-cause mortality in COVID-19 patients. And this is a more recent study. There was also a Danish registry of about 4,500 patients of COVID-19 patients. And this also had a nested case control study within it of ACE and ARBs. And they again found no significant association between ACE-ARB use and severe COVID-19 outcomes. There was also very interesting evidence which came from the RAS-TAVI study. This was actually a TAVI study, patients who were getting the transcatheter aortic valve replacement in 14 centers in Spain. And the interim analysis showed that use of RAS inhibitors was associated with neither risk of infection nor poorer outcomes in COVID-19. So this was a nested control, an inbuilt study which was part of the RAS-TAVI study, which did not show any increased risk due to ACE inhibitors or ARB use. In very, very recently, there is another study by Zhang et al. Which has shown through meta-analysis of 13 studies, and they have clearly showed that the ACE inhibitors and the risk of mortality with or without antihypertensive patient medicines and the exposure or the severity of COVID-19 infections were not associated with ACE or ARB use. So in these 12 studies of more than 19,000 patients, there was no concern that ACE inhibitors or ARBs exposure is harmful in patients with COVID-19 infection. Then there was another study which came based on this data, and in this, they removed the Mehra et al. Study, which was actually withdrawn because of falsification. And when they revisited the meta-analysis, and they again came up with the the forest plot, which shows that ACE inhibitors and ARB exposure was not linked with increased mortality or severity of infection in COVID-19. So eventually, what has come out is that the ARBs, ACE inhibitors and ARBs are actually protective in patients of C19. And the proposed mechanism could be reduction of lung edema and vascular permeability, decreased apoptosis, pulmonary edema and fibrosis, reduction of TGF-beta. There is inhibition of coagulation cascade also. Yes. And there is less lung injury, less pro-inflammatory cytokine release, down-regulation of pro-inflammatory kinases, and so forth, and so many other, protective mechanisms. And if you look at the current guidelines, there are all the guidelines, whether it was European, European Society of Hypertension or Cardiology, Canadian Cardiovascular Society, have already strongly encouraged the continuing use of ACE inhibitors and ARBs in patients with COVID-19. And recently, even the Renal Association, United Kingdom, International Society of Hypertension, all of these Spanish, American, ACP, AHA, etc., all have recommended continued use of ACE inhibitors or ARBs in COVID patients. So in the end, I would just like to reiterate that when you approach a patient of hypertension, there across the board, all consensus is to use ACE inhibitors or ARBs and do not withdraw these drugs. Continue to use them. You can initiate also in COVID patients if they're hypertensive. And you should also, because you must understand that they decrease mortality and morbidity, especially in LV dysfunction, CKD, and secondary stroke prevention. Hence, these drugs should not be withdrawn and should be added the same way you have been treating the patients till now in the ACD the recommendation of hypertensive therapy. Thank you.
Thank you so much, sir. Thanks a lot for such a wonderful and informative presentation. Now moving forward, I'll request that the video should be played, the video by Dr. Peter Gillard from Belgium, speaking about the insulin sensors and the blood glucose level, the impact on blood glucose level.
Sir, Dr. Vinayak will be here, sir, for another half an hour?
Yeah, I'm here.
Okay. Yes, Dinesh, please start the video.
My name is Peter Gillard. I'm an endocrinologist in University Hospitals in Leuven, Belgium. Today, I want to talk about the use of sensors in times of COVID-19 pandemia. You might wonder what glucose sensors have to do with this virus. Well, as the number of people with COVID-19 increases, it becomes more and more likely that people using a glucose sensor will be affected. To reduce COVID-19 symptoms, such as fever and pain, people often take paracetamol, also named acetaminophen, which, especially if taken repeatedly and at high dose, can cause the glucose sensor values to falsely rise. For example, if the capillary value is 90 milligram or 5 millimole, the sensor might show a value of 180 or 10 millimole, or even higher. This can be dangerous, and it is important to take this into account. Do all sensors have this issue? No. One of the most commonly used sensors, the Freestyle Libre sensor produced by Abbott, also called the flash sensor, does not and can be used by most people while taking paracetamol. But be careful, As with all sensors, each sensor can deviate from the actual capillary values. So in case of any doubt on the accuracy of the sensor, a capillary measurement should be performed. In contrast, other commonly used sensors, such as the Dexcom G5 and the Medtronic Enlight and Guardian sensors, do show interference from paracetamol or acetaminophen. These sensors might therefore indicate a higher value than the real blood glucose value. Dexcom G5 users will recognize this. Sometimes the app on the smartphone fails to give a glucose value and indicates that there might be interference from paracetamol or acetaminophen. Because it's difficult to predict whether there will be a relevant interference, we recommend that patients rely on capillary measurements during repeated use of paracetamol. People who use an insulin pump that is connected to a Medtronic sensor for instance, predictive or low glucose suspend features, or in hybrid closed-loop settings, are advised to switch off the interaction between the pump and the sensor when paracetamol is taken, repeatedly or at high dose. Other sensors, such as the Dexcom G6 and the Eversense implantable sensor, do not have this interference and can be used safely. Another thing, paracetamol or acetaminophen are sold under very different brand names. So physicians should always advise their patients about this possible interference when prescribing drugs containing paracetamol. But also take into consideration that a single dose of one of these drugs is less problematic, since interference with sensor values, if any, will be short-lived. Finally, I would like to wish everyone a lot of courage and strength in these often difficult and strange times. But I am certain that we as a diabetes community will overcome this.
Thank you, Manish.
Thank you, Manish, so much. And I hope the video was informative and relevant for today's topic. So, you want to say, Vaneet, something?
No, I think we can start with Dr. Prabhat and then we'll take on the question answer.
Yes, sir. So, Dr. Goel, please take us through the second presentation, that is management of diabetes in COVID pandemic. Thank you so much.
Am I audible?
Yes.
So
Yes, sir. Yes, sir, you're audible.
First, I thank Anil Sharma ji and Abhay for kind words, and I must congratulate Dr. Vinayak for an updated and exhaustive presentation about hypertension. In fact, hypertension is the commonest comorbidity which we see in patients with COVID. So now I am coming to the second part of today's program, that is diabetic management in COVID pandemic. I will be not going into so much of theory. In fact, I will be discussing few practical points. And as this has already been covered with Dr. Vinayak, the most people with COVID-19 has comorbidities, especially hypertension, diabetes, and cardiovascular disease. And these people who are having comorbidities have worse outcome. And especially it is now known, if the patients with COVID-19 present with hyperglycemia, whether they are diabetic or not, they have worst outcome. Coming to the diabetic part per se, it is also one of the three commonest comorbidities which I have listed. Now, patients with diabetes as such are not at risk of developing COVID. They are not having a higher risk than the other population. But if they developed COVID, then the outcomes are worse for these people. Now, this part has already been covered in detail by Dr. Vinayak about the ACE2 pathway and the expressions. But what I want to highlight here is that ACE2 is also present on pancreatic islet cells. And when this virus gets attached there, it causes insulin deficiency. Hence, in many patients with COVID, you may see new onset diabetes, especially in elderly individuals. And all those individuals who have risk factors of developing diabetes, like obese people, they may present with new onset diabetes during this COVID disorder. Now, in this pandemic, we have to prepare our patients with diabetes how to keep themselves safe. That is a first part. And the second part is that if they develop the symptoms of COVID, then what they should do. Now, this is for prevention part or to prepare them. And we must stress with all the patients who are having diabetes, they should maintain a healthy lifestyle. They should eat regular meals. They should follow their dietitian advice. They should limit their refined sugars and carbohydrates. They must consume adequate amount of vegetables, 2 to 3 servings of fruits every day. They must consume nuts. Coming to the physical activities, I think most of the people are afraid of going out. So they must do indoor exercise. At least they should walk in their homes only. And what I tell everybody, to my diabetic patients, is that every 2 hours, they must walk for 10 minutes. So if they are awake for 12 hours, they are indirectly walking for 1 hour in their house. And if all those people who are working from home, they should take now regular active breaks. They should again get up from their chairs and do something at least 2 to 3 hours, after every 2 to 3 hours for 10 to 15 minutes. Smoking should be avoided, and they should avoid alcohol intake. And stress management is very important part during this COVID pandemic. So this is what I was saying, we should always tell our people what is optimal metabolic control, what is good for them, and they must maintain a good metabolic control in present scenario. They should, instead of coming to the clinic and exposing themselves, they should go for telemedicine, or they should connect their healthcare provider whatever way they want, and they must optimize their medical therapy. They should not discontinue whatever treatment is going on their own will, and the doctor or whatever healthcare professional they are consulting with must know what they are taking and what they want to discontinue. Without their consent, they should not change their therapies. Now, good glycemic control may help in reducing the risk and severity of infection. They must monitor now blood glucose level more frequently. In fact, there are guidelines which suggest that there are few people who may not require glucose monitoring very often. But now I insist everybody to have glucose meter at their home, and they must monitor their levels more frequently now, and they must monitor for early signs of hyperglycemia so as to maintain or so as to adjust their therapy so that the control should be optimized. This has, I think the last video was this only, inform patient that paracetamol, especially if taken repeatedly in high dose, may cause false rise in some glucose sensor values. Most of my patients, without my notice, are also consuming high dose of vitamin C. Now there is a problem. The now glucometers can give you the false high reading if your patients are taking high doses of vitamin C. So paracetamol interact with the sensors and vitamin C interact with glucometers. So situation become little catchy. So ask the people not to take excessive amount of vitamin C as many people are taking nowadays. Beside diabetes, CV risk factor and lifestyle management forms the important factor that one should not forget during this outbreak. As we have seen earlier, beside diabetes, it is a hypertension and the cardiovascular disease which carries the worst outcome, and management of hypertension and other cardiovascular disease, as Dr. Vinayak was telling, must go side by side, and one should not ignore, especially if your patient is having coexisting heart or kidney disorders. Nutritional deficiencies should be treated. Always encourage about exercise, because exercise is also known to improve the immunity, and one must ask the patients to take vaccinations even during this pandemic time. As this was discussed in the earlier talk, hypertension was the most prevalent comorbidity reported in patients with COVID-19, and blood pressure control is essential for managing diabetes and is recommended for protection of kidney and heart-related complications. So ensure your patients are aware and prepare in case they contract the COVID infection. We must tell them the sick day rules. Even if your patient is safe at home, you must tell them in case they develop fever or any manifestation of COVID, what they have to do. And as many of these people are not going out, they must have adequate supply of medication, especially if they are going to be isolated or quarantined if they develop COVID-19 infection. Now coming to what are the consensus recommendations for the management of diabetes during this pandemic. Basic rule is monitor and seek advice. I will discuss the medication part later on. We must ensure they have adequate hydration. Hydration is maintained. They must drink plenty of water and try to eat as normal as possible if they develop any manifestation of COVID-19. Blood glucose, if monitored routinely, they should monitor more frequently after every 4 hours if they develop fever, and they keep the record, and they must share this record every day with their doctors. They must check for symptoms of high blood glucose like thirst, dry mouth, passing large amount of urine, feeling excessive tiredness, and weight loss. Now, these can be sign of viral disease per se also, tiredness and weight loss. But if they are monitoring their sugars, they will immediately come to know their sugars are going high. If possible, they should check urine ketones, and they must monitor their temperature and oxygen values, saturations. But when they should take urgent help or when they should go for admission. Number one, if they don't know what to do, it's better to come to the hospital. If they are vomiting repeatedly, they must come to the hospital. If their sugars are more than 200, 250 for last 24 hours, immediately report to the emergency department. And if they are showing any signs of decay, it's an emergency, immediately rush to the hospital. And signs of and symptoms of decay is ketones or blood in the urine, excessive thirst, dehydration, polyuria, shortness of breath, labor breathing, abdominal pain, leg cramps, nausea, vomiting, mental confusion, drowsiness. If they have fruity smell, they must immediately report to any emergency of any hospital nearby. Decay occur in patients with type 2, and it can occur in type 2 diabetic also if they are severely ill and if they are on SGLT2 inhibitors therapy. It requires immediate hospitalization, and as soon as you feel your patient is not eating properly or is going for moderate disease, SGLT2 therapy should be immediately discontinued. As I told you earlier, there may be few patients who may present with new onset diabetes during this pandemic. And then what we should do if your patient with diabetic develop infection? So plasma in a hospital, one should monitor for glucose, electrolyte, pH, and blood hydroxybutyrate. They should be given adequate amount of intravenous fluids. They should be shifted to IV insulins. Generally, in emergency settings, we must go for IV insulin therapy because subcutaneous absorption can be erratic. But if your hospital is not having facility, or if you are not having able to monitor IV insulin infusions, it is better to give subcutaneous insulin also. Giving insulin is better than not giving insulin or keeping insulin in the backyard thinking you don't have facilities. If you don't have facility to give IV insulins, it is better to give subcutaneous insulin. What are the aims then? We should keep plasma glucose concentration somewhere around 140. HbA1c should be less than 7. If your patient is on continuous glucose monitoring, then what we want, the time in range should be more than 70%, but if your patient is old or frail, it should be more than 50%. Hypoglycemic episode should be as less as possible, less than 1% for frail and older people. And if you are doing plasma glucose monitoring, then it should be between 70 to 180. Generally, we keep it around 140. Now I will discuss what should be done to the regular medication which patient is taking and if he develops COVID infection. Coming to the metformin, it is the commonest drug and most of the time your patient will be on metformin. Now dehydration and lactic or acidosis will probably occur if your patient is dehydrated, and if your patient is dehydrated, it may cause problem. So hence, if your patient is severely ill, if he is not able to take, then stop metformin. And during illness, renal function should be monitored carefully. But if your patient is having mild disease, if he is able to eat and drink, metformin can be continued. Coming to the sodium SGLT2 inhibitors, now these are one of the most sought after drugs nowadays because of their extra glycemic benefits. But if your patient is having vomitings, if he is not eating, if he is having very high fever, stop this drug immediately. In fact, one group of experts says if your patient develops first sign of COVID, immediately stop SGLT2 inhibitors. Avoid initiating therapy during respiratory illness, and again one should monitor renal function and to see for acute kidney injuries. Coming to the GLP-1 analogs. The common drugs which we use in India is dulaglutide and then liraglutide. Lixisenatide, SEMA is not available at present. Again, dehydration is likely to lead to the serious illness. So these are the patients who should stop GLP-1 analogs and should be closely monitored for renal dysfunction, and their adequate fluid intake and regular meal should be encouraged. Coming to the DPP-4 inhibitors like vildagliptin, sitagliptin, linagliptin, saxagliptin. Now this is the only group of drug which doesn't have any interaction and can be used safely even during this pandemic. They can be continued in most of the people, but if your patient is becoming severely ill, then all the oral drugs has to be stopped and these patients will be shifted on insulins. But more or less, DPP-4 inhibitors can be continued safely in most of the people who are having COVID-19. Insulin therapy should not be stopped. In fact, if your patient is becoming seriously ill, we have to initiate insulin, but we have to adjust the regular therapy so that their control should be optimal and they should not develop hypos. But what about the other drugs which these individuals are going to get? what they can cause to these individuals. Chloroquine and hydroxychloroquine, I think few months back, everybody was using that. But be careful because chloroquine and hydroxychloroquine can cause hypoglycemia. They are insulin secretagogues. Beside this, they can cause prolongation of QT interval. And if your patient is having associated cardiovascular disease, most of the diabetics will be having associated cardiovascular disease. It may cause problem. And if you are combining hydroxychloroquine with azithromycin, it will further cause problem because both drugs are known to increase QTc interval. Sometime in ICUs or in hospital settings, few people are using antiretroviral drugs also, but these drugs are known to cause hyperglycemia, which may have some problem in the glycemic control. These drugs also interact with the statins. Now, we have to be very careful because unknowingly or knowingly, we may cause harm to their liver if we are using these retroviral drugs and high-dose statins. Glucocorticoids are commonly used in hospital settings, and again, these drugs can cause hyperglycemia and may predispose for secondary bacterial infection. Remdesivir is a new kid where everybody is going after, especially in ICU setting. The drug is hepatotoxic, and again, we have to be very careful when you are using this drug with statins. And we also say in lectures, diabetic patients have hidden liver dysfunction. In fact, most of the diabetic patients have some amount of fatty liver and hepatic dysfunction, and these may increase with these drugs. So this is what I was saying in nutshell. Prevent infection in people with diabetes by continuing the regular glucose lowering therapy. They should monitor their glucose more often. They should watch for their urinary ketones. They should be having good lifestyle. They should minimize their exposure to the virus by avoiding visit to the unnecessarily or non-emergent visit to the healthcare facility by adopting telemedicine. And as Dr. Vinayak was saying, ACE and ARBs have repeatedly shown to be beneficial in patients with this infection, so they should continue with their ACE and ARBs. Vaccination is must, but if they develop COVID-19, then if they are asymptomatic or mildly symptomatic, they may continue with their usual therapy. There is no need to change their therapy, whether they are at home or whether they are in the hospital. But if they develop symptomatic disease, then they should be admitted, and one should withhold SGLT2 inhibitors, and they should be put on insulins. If they develop severe disease, then they need ICU care. They should be put on insulins, preferably IV insulins. But if facility is not available, then multiple dose subcutaneous insulin will also suffice. And one should not forget associated comorbidities, and we must use ACE and ARBs, statins, but one should be very careful when they are very severely ill, because all these drugs can cause some problems and we have to adjust their doses, or sometimes we have to stop them also. But whatever we have discussed, would tight glycemic control lead to the better COVID-19 outcome will be the big question. We know diabetes people have higher mortality, they have worse outcome. The risk of getting a disease is not much, but risk of having a severe disease is very large. But whether this help in better outcome, probably answer we don't know. There is some data which suggests it is helpful, but at present, as far as I have studied, we don't have any data whether good glycemic control during the disease periods help in better outcome. We have a data, controlled diabetics do better than uncontrolled diabetics, But during this phase, whether managing diabetes very well lead to a better outcome, I think we don't know at present. So in summary, COVID outbreak has changed many things in our life. Even the doctor-patient relationship has also gone some change. There is a strong association exists between diabetes and COVID-19, and practical recommendation, though they are changing very fast, we must study and try to follow in managing our patients. Thank you very much.
Thank you so much. Thanks a lot, sir. That was a wonderful presentation. Now moving forward to the questions and answers. So I'll just try to read it out. So our first question is, if the patient is on taking vitamin C 500 mg daily, how much is the blood sugar rise expected?
Sorry, vitamin C doesn't cause increase in blood sugar.
Correct.
It is the blood glucose monitor which will give you the high readings. As the video in between, the endocrinologist video which was showing, if your patient is taking high amount of paracetamol, the sensor will wrongly interpret the value because it cross reacts. Similarly, what happens, vitamin C has very high redox potential. It will compete with the glucose level and will falsely increase when you will put the blood on the glucose strip, the color change which will occur much more what glucose can cause, and your glucometer will read higher levels. There is no formula to say this value will cause this much high sugar. What we want to say, vitamin C interact with the glucose in glucometers, and your glucometers may give you falsely high reading when your patient sugar levels may be normal or they are little low. The problem comes if your patient is on secretagogues, sulfonylureas or insulins. You try to adjust the dose according to the reading which glucometer is showing, and in fact their sugar levels are normal. Now, because of this secretagogues and because of this insulin therapy, they will land up with hypo. Symptom will be your hypo, and your glucose levels will be showing with something like 140, 150 or 200.
Okay, sir. So basically they are false positive.
How relevant it is or whether Indians are using it or not. Look, it depends upon what type of practice you are having. If somebody is living in the metro city and is attending a big corporate hospital, for example, Dr. Vinayak work in PSRI, their endocrine department must be having people who are on continuous glucose monitoring, who are using pumps. He was in Medanta earlier. They have so many people who are on pumps. The problem comes there. I am a primary care physician. I will not see pump people. But when we are presenting any data, it's a duty to give us the whatever information is available. Its idea is whether it is relevant or not. Even if one patient we see who is having on pump and his paracetamol interact with it, it is better to save them.
Okay, sir. Thank you.
Right.
So the next question is, what is your opinion on ICMR's announcement to launch vaccine by 15th of August? I mean, this is, I think, for both the speakers. So
I think everybody knows. I think everybody knows this answer.
See, I agree with Dr. Prabhat that the vaccine we have to understand what are we expecting from vaccine, right? Now, number one, we know that the virus has a potential to mutate. We also know that the viruses, what is the level of immunogenicity of a vaccine is very important, whether it will be able to generate enough immunogenicity to evoke antibodies which are protective. Number three, the adverse reactions. Number four, the production. Number five is the distribution. Number 6 is the finances. So vaccine may sound as a very, a glorious concept and something which will, be
Magic
like a magic wand which you wave and corona is going to go. I think coronavirus it is not the first time such a virus has come. It will continue to come even in future. And I feel what it has taught us is very, very valuable. Number one, what it has taught us is that our preparedness for such kind of pandemic should be always there. Number two, as doctors, we should know how to protect ourselves and also to protect others. Number three, the public at large has to understand that they should wear masks and social distancing even in otherwise situation. Even when the pandemic subsides, this virus is not going to go away. It will keep trickling in, just like swine flu, it will keep trickling in, for about next 2 years. So I think these are some thoughts which I will share is that please maintain your basic 3 principles. One is the droplet and the aerosol, the airborne prevention. The other is your social distancing. And the third is the surface disinfectant or hand wash, etc. I think that's about it.
Okay, sir. Thank you. Thank you so much. So we are done with the questions. So I'll hand it over to Vaneet, sir, to give a vote of thanks.
Thanks, Dr. Mane. I would definitely like to thank Dr. Vinayak Agarwal and Dr. Prabhat Goel for the definite enormous talk on management of hypertension in COVID as well as in diabetes. Sir, we have close to 1,400 delegates today, and I'm sure they all would have loved the presentation and the answers that you have given for very, very precisely for their questions. Sir, I personally thank you once again that on a working day, you have taken out time for us to be present here for more than 1 hour. I thank one and all the delegates also who have taken out time from their busy schedules. So this is an ongoing process, I understand, and we definitely will come back to you in case if more help is required from our side, sir. But thank you so much, sir. Thank you so much for covering. And I thank my team also, sir, who has also been very, very prudent in meeting doctors in such a kind of pandemic. We have been asking them to go to connect through online platforms, and they are doing it, sir. Requesting is please support them for our brand, sir, as much as possible. Thank you so much, sir. Thank you once again for your time.
Thank you so much, Doctor. Thank you very much, Dr. Vinayak and Dr. Prabhat. Thank you so much, Doctor.
Thank you very much. Bye-bye.
You have a wonderful session. Thank you. Bye-bye.
Bye, Dr. Vinayak.
Bye-bye.